You are in the session for Inflammation and Immunology, Balancing the Risk and Rewards of Immune System Modulation and Treatment. So we're going to get started. So I do want to, I'm just going to check the clicker real quick. All right, great. So thanks for joining us today. Hope you're all having had a great morning session. We are a joint session today talking about several different topics. And my name is Katherine Liao. I'm a rheumatologist at Brigham and Women's Hospital. And I will kick off with an overview of the meeting, or the session. So the session will be in two parts. We will, in part one, is talking about shared pathways of rheumatoid arthritis and cardiovascular disease. And we will also talk a little bit about an interdisciplinary clinic, which you'll understand why we're talking about it shortly after this session. And myself and Dr. Brittany Weber will be leading this session. Then the second part will be about immune checkpoint inhibitors for cancer and autoimmune disease, and that will be led by Dr. LaBouffe and Dr. Sparks. And they will also be talking about another interdisciplinary clinic we have at the Brigham for rheumatology and oncology. So I thought I'd start by giving you an overview of how inflammation and immunity go together, because that is the theme of this session, and hopefully it'll make sense why we're talking about cardiovascular disease and checkpoint inhibitors as well. So those of us on the stage, and perhaps some of you in the audience, one of the first things you learn about when you learn about inflammation is the signs of inflammation: calor, dolor, rubor, tumor, which stands for heat, pain, redness, and swelling. So this was actually first described or written down in the 1st century AD by Aurelius Celsus, and this is still the same description of inflammation we use to this day. Now we know more about it. It's the body's response to physical injury, infection, and if the self is perceived as threat, we have autoimmunity. And it goes hand in hand with immunology, which now we understand what the response is. It's immune cells, mainly such as white blood cells, and the response can be local or systemic, acute versus chronic. And we'll be talking a little bit about that in this session. But our immune system, every day, it's doing a careful balancing act. In rheumatoid arthritis, which is one of the classic hallmark autoimmune inflammatory joint diseases, in fact, it's the most common worldwide, it's where the immune system, for some reason, reprograms and starts attacking self, mainly the joints, but you'll soon learn that it's systemic. And the treatment is by suppressing the immune system. On the other hand, we now have the ability to harness the immune systems to fight cancer. And so immune checkpoint inhibitors activate the immune system to target tumors. But as a result, you now have an overactive immune system that now targets self. So I'm going to just jump into this concept of RA and how it's linked with cardiovascular disease. Cardiovascular disease is the leading cause of mortality in rheumatoid arthritis. Patients with RA at 1.5 times the risk of having a heart attack, even if you were to compare them to the same person in the population with the same age, gender, risk factors. And this excess risk is attributed to inflammation. We now have multiple targeted therapies available for RA, but we also know that they have very different risk profiles. So I thought I would start with two cases. One is a 72-year-old man with RA. He had RA for 5 years, high blood pressure, BMI of 32, which is considered obese, and 25-pack year smoking history. Our second patient is a 44-year-old woman with rheumatoid arthritis as well for 2 years, no other significant past medical history other than a BMI of 33, and she is a non-smoker. So I think I just wanted to pose this question to those in the audience: who do you think has a higher risk for atherosclerotic cardiovascular disease? Well, it turns out both of these patients were in a study I was running at the Brigham where everybody got a stress test. And it turns out both of these patients had abnormal cardiac stress tests and were initiated on statins. And I think that most in the audience are probably thinking, of course, a 72-year-old man, high blood pressure, smoker. But the thing with RA and other inflammatory diseases is that we know that it's increased risk, and it's these younger patients that we really aren't capturing earlier, and we don't have a good way for capturing them earlier. Some of you might be saying, okay, well, they both started on statins. Maybe we should get everyone statins. And I know the cardiologists often tell the rheumatologists, not Brittany, that everybody should be on statins. Well, there was a trial on statins where they randomized RA patients over 50 years and other inclusion criteria, and they gave them statins or placebo to prevent primary cardiovascular events. They randomized about 3,000 subjects. The trial was terminated early because of lower event rates. However, they published their data with a median follow-up of 2.5 years. Everyone in the atorvastatin group dropped their LDL as expected, but what you're seeing here is on the right, you see the graph. The blue are subjects who are on atorvastatin. Green is placebo. So you do see a difference where there was a hazard ratio or protective effect of atorvastatin. However, this was not significant. So I think this tells us that statins are helpful, but maybe you don't want to give everybody with RA statins because with any drug, there are risks and benefits. And maybe you want to be targeting inflammation as well. Maybe that will help to close that gap we have in RA. So this is just one way of thinking about cardiovascular disease in RA. So in blue, we have the RA patients. In red are the patients with high ASCVD risk. So we do have, when you go to your primary care, they're checking your cholesterol and they're punching your numbers into a calculator to kind of get a sense of what is your 10-year estimated atherosclerotic cardiovascular risk. That's that ASCVD risk I have on there. So there are definitely RA patients who we can capture with these general population-based calculators. But in yellow are the population where, we wouldn't capture. There are people like NM, the 44-year-old woman. If you calculate her risk is 0.8%, so you're never going to be thinking about starting her on statins. And I think this is one of the reasons why the population studied in TRACE-RA, you didn't see a difference because you're capturing people with true risk, but also those who really aren't at risk. So is there a better way to do this? And we really rely a lot on our colleagues on helping in this data-free zone. So I'm just going to end this short session, this short segment here, to talk about this convergence we're seeing between how we're thinking about the pathogenesis of rheumatoid arthritis and autoimmune inflammatory joint disease and treatment for atherosclerosis, where there's this convergence of pathways where you see that IL-6, IL-1, they're both they're definitely targets for RA, and they're targets of interest for atherosclerotic cardiovascular disease. In RA, at least, there's been a paradigm shift. I showed you those two patients earlier. We have about 13 plus treatments for RA. Our goal as rheumatologists is to control disease activity, but now we're also thinking about what are their comorbidities? What drugs might be helpful if they have cardiovascular risk and give additional benefit? And this is where I wanted to highlight, and I'm going to segue to our next speaker, Brittany Weber. In the absence of data, we have an interdisciplinary clinic, cardiovascular clinic in cardiology and in rheumatology, which we call Cardio-Rheumatology, to help guide and kind of create this environment to try to figure out what are best practices as we're working our way on the research side to try to better understand how to better manage patients with RA and other rheumatic diseases for cardiovascular risk. Okay, so with that, I'm going to segue over and introduce Dr. Brittany Weber, who's the director of our Cardio-Rheum Clinic.
Thank you very much, Kat, and thank you to the organizers for this opportunity today to talk to you a little bit about what I'm very passionate about, and that is the field of cardio-rheumatology. Make sure the clicker works. So today I'll be giving you kind of a brief overview of what the cardio-rheumatology clinic entails and what are some of the unique challenges moving forward we all have in this field. So one, it is known that there are many diverse manifestations in which autoimmunity, pro-inflammatory, systemic inflammatory skin diseases can affect the cardiovascular system. This is well beyond just atherosclerosis, which you kind of heard at the very beginning point of those two cases that Dr. Liao mentioned. I like to think about it in broad buckets because of this diverse nature. We can think about it in the vasculature, the pericardium, valvular disease, myocardial disease, and electrical. And for instance, if you just look at the diagnoses, these are all things that can occur in patients with systemic inflammatory conditions and autoimmune conditions. Some of these are not unique to them. They'll be seen in the general population, such as your bread and butter accelerated atherosclerosis, although there are some that are quite unique to each disease subset. And you can see the diverse manifestations of which cardiologists are now struck with having to understand the complexity of these diseases. Also, in 2023, we're only getting more complexity. It's an increasingly complex field, and this is just a few photos to highlight this. In 2020, we had the COVID pandemic, in which we had drug shortages at one point in time for hydroxychloroquine when this was utilized as a therapy, and we also had concerns, all these concerns that people may remember that were put on the website and on the TV, and these are patients that these are mainstay treatments for many of our diseases within rheumatology. And then you look at the right here, and this is something that's become an increasingly common referral to the cardio-rheumatology clinic is now one of a very common medication that a patient with rheumatoid arthritis or psoriatic arthritis may go to when they failed other inflammatory treatments is JAK inhibitors. Well, in 2021, there was an FDA label warning of a cardiovascular and cancer risk signal. So now we are struck with this, what do we do and how do we optimize our patients and how do we decide when that risk exceeds the benefit of the drug that can cause their inflammation? There's still a lot more to come on this. And then the bottom left is something that's not new, but is, again, highlighting the unique challenges of these population, and that is, you heard from Dr. Liao about the role of statin therapy, but even when we decide our patients will benefit from one of the most primary prevention cardiovascular medications, we are taking care of patients that chronically have myalgias, joint pain, and if you just do a quick Google search, which I did this weekend, you get over 3 million hits within half a second of the term statin myalgias. And actually, this picture I'm showing you here is an article I found on the New York Times. It actually was talking, and this is what our patients see about how statins can make you exercise less. It's not the right message we should be sending to our patients, but again, the notion here is this increasing complexity of the field. In addition, as a cardiologist, and I'm also a cardiovascular imager, we have an expansion of cardiovascular imaging tools. It's kind of like a kid in a candy store. I have this huge sandbox, but this is also the need, this complexity of the understanding the role of imaging within our patients with inflammatory conditions, what each one, there's pros and cons with each of these tests, but you can see here, we are much more in 2023 beyond the role of just standard exercise EKG and echocardiography. Now in my clinic, I frequently utilize much more advanced, non-invasive imaging modalities such as stress cardiac perfusion PET. You can see here, this is one of the only tests we can look at the microvascular, and so that is a very highly beneficial test I can utilize a lot in these patients. We have coronary CT, and we now have this new technology that allows us to image the inflammation around the coronary vessels. Again, a new technology coming, and stress cardiac MRI, we'll be able to get much more detail of the morphology of the myocardium and pericardium around patients, and this is actually one of my patients shown here with lupus pericarditis, which is inflammation around the heart lining. And so in this short kind of overview of cardio-rheumatology, I won't have time to walk through these typical patients that come to our clinic that we see because of their complexity, but I wanted to utilize this one slide to show you what this clinic entails. This is one of a patient that was referred to me by a rheumatologist here at the Brigham with ongoing subtle chest discomfort, actually after he had already had an evaluation by an outside hospital cardiologist and was told he was normal. He had psoriatic arthritis and still had symptoms I was concerned about because of this known association. And we did further advanced imaging, and what we found was something that nobody wants to have found, but one that we are glad we found to prevent, which is severe three-vessel coronary disease, to the point that's the middle part of the picture, and that actually was enough to necessitate early cardiac surgery referral, and within 2 weeks he had a cardiac bypass. He's now doing wonderful, but what this case highlights is the increasing complexity of our patients and the need for us as providers to understand this complexity and also how we can evaluate these patients when they come with these symptoms. And so to kind of wrap it up here, I hope I've given you a flavor of really both the excitement of the field, but also the challenges we all have to face. And what has become very clear to me, although my colleagues up here are wonderful and amazing, they simply cannot do everything, and they're quick follow-up visits that we are now poised with in our clinic models. And so this is the need for early recognition of cardiovascular risk, to discuss weight loss, lipid management, blood pressure management, lifestyle, and also understanding these rheumatologic drugs and their cardiovascular risk signals. You just heard from Dr. Liao that RA now has over 13 treatments, one now with a cardiovascular black box warning. And so we have to understand this as cardiologists and how we think about, with the rheumatologist, what are the best therapies for our patient. And hence, that is the need for collaborative care. There's a lot to be done for advancing the field of cardio-rheumatology. I think it's a very exciting time, but this is the need because these conditions are less common than the general cardiovascular studies. We're never going to be able to do these large cardiovascular studies you see in cardiology, and that is the need to be building these future collaborative models across the United States and elsewhere so we can start to understand and address these important questions moving forward. This just shows you some pieces to the puzzle, but a lot to do for the future. And with that is going to take collaboration. Although we are still in the infancy, there is some fuel to this fire. And this was a Medscape article that was published recently that actually shows you that it is not just the Brigham, although we are still one of the few, but there are a growing number of clinics popping up across the United States, which is very exciting. And many, almost actually every single one of these clinics we've been in contact with, so we can further do research to start to understand some of those questions. And so with that, I'd just like to end this first talk and thank you. And also just put a plug here for the Cardio-Rheumatology clinic you'll see here. So thanks very much.
Okay, I think to conclude this session, we wanted a brief Q&A moderated by me.
Yes,
And
moderated
if you
by
have
you.
questions, certainly let us know. We'll have some time at the end as well. So it sounds like there's a lot of exciting things going on nationwide, not just at the Brigham, but we have a very unique resource here.
Yeah.
So clearly, RA patients are at higher risk for cardiovascular disease, and it seems like you could think about something intrinsic to the disease. You could think about lifestyle. You could think about medication. So I wonder if you could talk about how do you deconstruct what this elevated risk is?
Yeah, do you want me to start? So, for a long time we've known it's inflammation, and it's just this big bucket, right? We're trying to break it down. What are the pathways? What are the things we should do? How much of it is due to traditional risk factors? And I'd say where we are right now is we know that RA patients aren't seeing their PCPs as often as they should, and taking care of lipids and obesity. But there's a big piece that's inflammation, and we've now had several studies trying to figure out, well, do any of our drugs actually, can it reduce the inflammation? Is that pathway specific for reducing cardiovascular risk? I'd say we don't have any real answers, and what we also know from the trial that Brittany pointed out is that just reducing inflammation is not the answer. So there was a big trial, Brittany referred to this. It was tofacitinib, which is a JAK inhibitor, versus TNF, a tumor necrosis factor inhibitor. And there was a safety signal for JAKs compared to TNF. So that just tells us, it just tells us that reducing inflammation isn't all the same.
And so, I'll just add to that. I think it's there's certainly an area where we know more is to come. When I see these patients in my clinic, I talk not just about their underlying systemic inflammatory disorder and what drugs they are on to treat that, but also about all those other risk factors. I think that's incredibly important because we know that those things all play a role in cardiovascular risk. But there's more to the puzzle here. And I think that this is really where the innovation is coming in and the excitement is coming in, is that it's not just the inflammation and we're now at the era with the scientific advancements that we can now start to tease out these pathways and understand what is it about inflammation. And what's really exciting that Dr. Liao mentioned is that some of these drugs that are standard treatments for rheumatoid arthritis patients, we're now actually doing large-scale cardiovascular trials to try to reduce cardiovascular disease in the general population. So these shared pathways, I think, are going to provide a lot of unique insights in addition to helping care for our patients with these underlying autoimmune conditions.
Yes?
I would like to ask a question, and I really appreciate that we were saying about the complexity, but I really like that. And I was wondering that because especially with the cardiovascular disease risk and all of that, we know that like women and men, they don't share the same risk, and also we're thinking about different ethnicities. They are also different risks. So I was wondering how you integrate that into your clinic and also into your research efforts.
We can summarize.
Yeah.
So I was saying, like, I appreciate the complexity that you brought.
That's inflammation.
I was saying that I appreciate the complexity that you brought in your presentation, and as I also said, that women and men, they don't share the same risk when we're talking about cardiovascular risk, and also different ethnicities, they also have different risk. So I was wondering how you integrate that into your clinical practice, and also thinking about your research effort, and if you have any innovation or any ideas that you can actually share. Thank you.
No, that's a great question, and one that I wish I could answer better than what I will tell you, but I will say that you were spot on, that there is more and more appreciation of both unique and shared risk that women may have more than men, and also it's also important to recognize sometimes different symptoms, right? For instance, I can tell you one example. Not only have we found that patients with inflammatory conditions have a higher prevalence of microvascular dysfunction, women have a much higher prevalence if you just look at women and men. Both of that's still vessel disease of the small vessels, which still carries risk. And so it's understanding these differences between the sex differences, the ethnicities, like you pointed out, and also thinking through when we integrate this with our patients of other things that will happen that are unique to women, such as menopause transitions and all these things that were risk changes. So I absolutely agree, and I think that many of our patients with these inflammatory conditions are female predominant, but not all, right? Lupus, a very female predominant condition, where psoriasis, another big bucket that I see and study in the research lab, is more 50-50. So I think starting to understand these gender differences will be important in the future.
So I can make a comment about diversity, which has been a challenge in research studies. So actually, Dr. Weber and I both, we both see patients in cardiology and rheumatology. We actually do research together,
Yes.
which is really exciting. And we try very hard to recruit a more diverse population. I'd say that's still a challenge, but what is getting better are these All of Us, such as the NIH All of Us project. I work with the Million Veterans Program. We're starting to see these larger diverse cohorts where we can ask these questions, or at least start asking the questions.
Yes?
So I can imagine that it would be tempting in cardio-rheumatological diseases to look at the DMARD drugs against the drivers of disease, like TNF-alpha, IL-1 beta, IL-6. But they all reduce immune competence, and of course the population that's most prone to these diseases tend to be elderly. They're the population least capable of withstanding a reduction of their immune competence. How do you conceptualize this conundrum? How do you work around it?
The easiest population is our rheumatic disease population. So I'm going to start there and then pass it over to Dr. Weber. So yes, I think in our patients for rheumatic disease, they need it anyway, right, to control their disease. And I think over time, we've already weighed the risks and benefits of immune suppression, risk of infection with controlling the disease, reducing joint damage, disability, and reducing cardiovascular risk. So for us, it's about picking the right one. But then, as Dr. Weber mentioned, these drugs are being used on people who don't need it for their autoimmunity. And I think there's more, it's more on the experimental side right now rather than in clinical practice.
Right, and exactly adding to her point is that in the general population, in patients who don't already have an indication, on these approved drugs to treat their autoimmune conditions, we now have data that's come out of the Brigham, both from Dr. Libby and Dr. Ricker, along many other investigators over many years, of showing the importance of these pathways. I will say the biggest trial in cardiology was the CANTOS. It was kind of this proof of principle trial that showed the role of IL-1 in cardiovascular risk reduction. And so this was a trial in which patients who had an event were actually given this therapy and shown in a large outcome-based trial. We've also had neutral trials with low-dose methotrexate. That was a CERT trial that many people may be aware of, that showed us, this theme is that not all inflammation is equal. But what I think is exciting is there's now been the release of a very large trial that we're recruiting for, even at the Brigham, called the ZEUS trial, which we're now giving patients without known autoimmune disease who have high cardiovascular risk, high levels of inflammation defined by CRP, an antibody that blocks IL-6. And so it's an important question you're asking about the age. You're right that many of these patients will be older, and if we just take it back to the rheumatic population, many of their diseases start much younger. So I think there's kind of two answers to your question. I think we need to understand how to recognize risk at a younger age, and also how to target the right therapies for the people that may be more vulnerable to the different pathways being blocked.
And another medication is colchicine, where there's a lot
Yes, exactly. Yeah, I should mention colchicine. We've now had both primary and secondary prevention trials showing risk reduction for the general population with colchicine, and I actually utilize it in my clinic all the time. It's a very safe medication. We all know about, right?
Yeah.
They use in their space a lot with gout.
Use it a lot. But can you comment on the uptake of that? I feel like it's more in certain centers.
Yeah,
Is that true?
It's not in certain centers. I will say there's certain maybe it's more provider based.
Yeah.
I will say that I think as I've seen just being on the younger side, that sometimes I think things take a long time to kind of change clinical practice. If we just look at even the development of the uptake of SGLT2s, that's been the new blockbuster drug in cardiology. And although I think we're at the Brigham, we want to put them in drinking water for our patients who are admitted, but I will say that if you look overall, it takes time for these new, innovative drugs in the market to transition over.
I think we had one last question.
Yeah.
Oh,
We have questions at the end as
Yeah.
well, just so you know.
All right, good stuff. No, thanks for having the panel and going over this. You talked about collaboration
Yep.
with
Yeah.
taking more of a holistic approach. Oh, thanks.
And
taking more
posterity, maybe.
Sorry?
I don't know if there's a recording, maybe. That's what the microphone's for.
Oh,
Yeah.
so
that's
from a
why it's
holistic
gonna
approach,
be-
actually speaking from firsthand experience and going through a holistic approach
Yeah.
between both really Western and Eastern medicine
Yeah.
from inflammation standpoint, how much conversation is it with folks, with your patients to speak with, have conversations with naturopathic, holistic doctors to do a more holistic approach between Western and Eastern medicine? Again, I say that from someone who's experienced the benefits of both teaming up and working together, because my body used to be a tremendous amount of inflammation, and got that straightened out with collaboration of both parties working together. How much is that a part of the conversations that are currently going on?
Well, maybe I'll take this from the rheumatology clinic, and perhaps we can talk about this later as well when we have some more time. I have to say, the challenge in clinic is we have a certain amount of time to help understand what the process is, and these drugs, as the other audience member mentioned, they're potent and they're immunosuppressives. There's a lot of side effects, so we spend a lot of time teaching about these drugs, side effects, risks and benefits. That I think we are focused more on the Western side, where we have data to show.
Yeah.
It's very hard, and I have to say I'm very open to, I have patients who are doing both, but I don't have the data to try to integrate it together to find a good path forward based on evidence, and that's, I think, where the challenge is.
I'll just add to that. I think I'm the same way, where we're more limited. I take a very kind of overall approach to the patient, discussing what works for them, what exercises work for them. I will say, I frequently get asked about supplements to help with myalgia. It's not that, a lot of the challenges that we don't have data, and a lot of these meds can interact. And for instance, if you're on a blood thinner, certain supplements could actually make you more prone to bleeding. So I'm always just very, very open in the discussion with my patient, and also what we know and don't know. And I think as a scientist, my PhD is in immunology, so I think I always come down to what are the data. So I'll tell them, coenzyme Q, many people take it for statin myalgias. We actually don't have great data on it, but it's not one that's going to be harmful in any way. So I just have those discussions with the patient through shared decision
All
making.
right. I think we'll now go to part 2 of the session, which Dr. Nicola Buff will kick it off. She is the Chief of Oncodermatology at Brigham and Dana-Farber, and a close collaborator, so looking forward to this session.
Thanks, Jeff, and thanks for having me. Again, I'm an oncodermatologist, so everything I'm going to talk about today is going to be viewed through the lens of the skin and as a dermatologist, but I think most importantly, what I hope you take away from the whole session is that it really crosses basically every subspecialty of medicine when we think about inflammation, and the skin is just a really good avenue for study. And as a clinician first, I always like to bring it back to the patient, so I'm going to tell you about this lovely 78-year-old woman with a melanoma that was diagnosed initially in 2012. It was appropriately surgically treated, and 4 years later, she developed some fatigue and back pain, got a PET CT scan done shortly thereafter. And for those of you who are not clinicians in the audience, basically almost everything that is black here are tumors, so she was riddled with cancer and deteriorating extremely rapidly. She got her first dose of a novel checkpoint inhibitor, a PD-1 inhibitor, immunotherapy, 2 weeks later, so pretty quickly. And at that point, at her first dose, she and her family had completed planning her funeral. So she was emaciated and deteriorating and basically on the brink of death. She had her first scan 12 weeks or 3 months later, and this is her scan. So within 3 months, the black that remains is her brain, her heart, her kidneys, and her bladder, and a little bit of a scratch on her wrist. She had an exceptional response to immunotherapy and was doing wonderfully until she had a little bit of an upper respiratory infection a couple weeks later and developed a rash diffusely. So her medical oncologist recognized a rash, gave her some topicals. The guidelines at the time said to put her on high-dose systemic steroids and to stop her checkpoint inhibitor, especially as her rash progressed. Her oncologist thought, boy, that doesn't feel very good. This woman is alive. She's playing tennis again. There has to be another way. Sent her to us in our skin toxicities clinic, where we diagnosed immune checkpoint inhibitor-induced psoriasis. We recognized that her arthralgias that were limiting her ability to play tennis were probably related, and we treated her psoriasis in a very targeted way. So her psoriasis responded. She was able to complete her checkpoint inhibitor course, and I'm happy to say that as of May 23rd, 2023, she is now an 85-year-old lady with no evidence of melanoma and minimal psoriasis on exam. So when we say that checkpoint inhibitors have revolutionized cancer care, we literally mean that we have seen patients brought back from the brink of death, where they have no evidence of cancer. And again, I'm young enough and also old enough to have existed in a time before these existed where all of these patients just died. There are now 11 FDA-approved checkpoint inhibitors across the entire cancer spectrum. They're included here, as well as some under study. And what they do is they take T cells, whose job it is to fight cancer, and they remove the inhibitory or the blocking pathways to allow them to go ahead and fight cancer. The trouble is, if you non-specifically take the brakes off your T cells and your immune system, sometimes your organs get in the way. And so we see diverse immune-related adverse events that are immune-mediated or truly autoimmune across every single organ system in the entire body. So this review is from 2018 in the New England Journal, and you'll see that these categories are pretty blunt in how they're described. If you just look at the skin, essentially what we see is that the clinical trials data and our medical oncology colleagues doing the absolute best that they can basically said things that are red are rashes, more specifically they're maculopapular rashes, and things that are white or had lost their pigment were vitiligo. And that's about the granularity of the clinical trials data across all of the organs. So colitis is basically a diagnosis to assign to patients with diarrhea who had inflammation of their colon. But we know now that sometimes it's celiac disease, sometimes it looks like ulcerative colitis. These are really blunt descriptions. And what we know from taking care of these patients in the clinic is that immunotherapy or checkpoint inhibitors actually cause dermatology. The entire full spectrum of every dermatologic disease that one person could get in the idiopathic or outpatient setting, they can get from a checkpoint inhibitor. And some of these are expected. So there's cytotoxic CD8 T-cell mediated diseases like lichen planus, but they're also neutrophilic disorders, they're antibody-mediated diseases. It's the full spectrum. And so the mechanisms at play have to be multifactorial. Now, the great thing about the skin, again, is on the one hand, the skin is the most commonly affected organ and the earliest to manifest immune-related adverse events. But we can see it, we can visualize it, and we can biopsy it. And so it's a great window into what may be going on internally in these patients. The other thing that this photo highlights, this slideshow highlights here, is that we are far past the time where we should expect our medical oncology colleagues to be able to handle all of the side effects of the drugs they administer. Asking a med-onc to be able to handle the immune-related adverse events across every organ system is like expecting a primary care doctor to never refer to a subspecialist. So we are at a time where multidisciplinary care is more important than ever. And this is really critical as FDA approvals continue to expand year after year. These drugs are being used in combination. And everything boxed in orange here is actually a non-metastatic indication. So this is where understanding how we can uncouple the toxicity from the therapeutic effect becomes even more important. We do not want to induce lifelong autoimmune disease with complications in patients who have no active cancer. So understanding this is really critical. So I was a fellow in clinic with Steve Hody back before the first approval when ipilimumab was being studied in clinical trials. And it was very clear, working alongside him, both his brilliance and also the limitations of his subspecialty understanding. He would say, Nicole, it's a rash. And I would say, Steve, it's lupus. And he would say, I got to give prednisone. And I would say, come on, Steve, let's give Plaquenil. And so it was really clear that there was a role for collaborative care. And so in 2014, after a couple of years of preparation, we launched our skin toxicities from anti-cancer therapies, or STAT program at the Brigham and Dana-Farber. And this model basically recognizes that there are care delivery models that can be innovative, that we can establish ways to educate both patients, providers, and sponsors about these side effects, and that if you set up a robust infrastructure, you can do robust clinical translational research, and that there are opportunities for innovation at every step along the way. And so it would be impossible, again, to tell you what we've discovered in the last decade or what we've brought to the table. But I will share just some highlights here, which is that we have shown that when you give medical oncologists access to expert urgent subspecialty care, we improve the diagnostic accuracy and specificity of those rashes, which in turn improves side effect management, including that we've shown that targeted biological therapy, targeted for the disease itself, specific for psoriasis or bullous pemphigoid, is associated with better side effect and cancer-related outcomes. When you embed and you are present alongside your oncologist, you actually improve their management choices as well. So even without our consultation, they do better. Patients are more likely to maintain their cancer therapeutic regimen without unnecessary treatment interruption or discontinuation. They're more likely to be re-challenged if the drug is held. And in the setting of immunotherapy-related rashes, as shown by our colleagues at Mass General, if you consult dermatology for the checkpoint inhibitor rash, your patients have better progression-free and overall survival. What we haven't yet shown is how important this is for quality of life, but we see this every day in the clinic. When it comes to research, by, again, setting up this model, we've been able to actually collect the tissue from with the generous donations of our patients to show things that, like novel imaging methods like tissue-based cyclic immunofluorescence, illustrated here on the bottom, is more powerful in understanding the immune profile of these patients. And by collaborating with really innovative folks like Dr. Ajit Nirmal in the Lab of Systems Pharmacology, we've been able to show that you can actually look at these cellular interactions in a three-dimensional way. So to get beyond, pure spatially looking at two-dimensional interactions, we see how the cells extend out their arms to actually interact. And I think these technologies have the potential to not only really move the field of how we understand checkpoint inhibitor toxicity forward, but all of our autoimmune sporadic diseases as well. So I think there's a ton of opportunity for innovation across the entire field. There's incredible overlap between onco, dermatology, rheumatology, cardio. I'm like, I should be sending all of my patients to the the cardio room clinic instead of just general cardiology. But that's where I think the innovation in care delivery really makes a difference. And so I will hand off to Jeff here to close us out and take questions in a minute.
All right. I'm so envious in the skin. Pictures are worth 1,000 words. I could tell you about joint inflammation, but those pictures just really tell the story. As you probably gathered by now, Nicole is like a true leader in this field and has really amassed a great collection that's very unique here at Dana-Farber, and I'm happy to be a participant on and learning from her and sharing patients. So this is an overview of the Immunotherapy Toxicity program. This is where all the specialties get mashed up in oncodermatology, oncorheumatology, me there on the left, but basically all of these providers are different subspecialists. We have endocrinology, hematology, GI, pulmonary, basically every specialty you can think about, because these medications really activate the immune system, and it still seems quite idiosyncratic about why some organ systems become inflamed and involved. Sometimes multiple are involved, so there's really a lot to sort out here. And as a rheumatologist, when I see primary diseases, one of the most common questions I get is, why did this happen? And fortunately, in this, we really know the trigger. We know exactly what the molecular mechanism is, we know the timing of it, so there's a lot that we can learn from our sort of primary diseases too about why patients veer off into different courses and why some don't have any of these complications at all. So this is a rheumatologist view of the same figure. So again, really, if you think about any organ system in the body, any of them can become involved in these immune-related adverse events that are triggered by these immune checkpoint inhibitors. The ones that I highlight in blue are really things that rheumatologists often get involved with. And probably the number one problem would be arthritis. You can tell that a rheumatologist did not make this figure because we would not say arthralgia. Arthralgia is really a pain. It's from a symptom perspective. Arthritis means that there's sort of, inflammation within the joint. There's cellular cells that have been activated. So it's a bit more subtle than that. We also get involved in myositis and myocarditis, inflammation of the mucous membranes that can cause dryness. And actually a good segue between both sessions is that when these complications happen, often we're repurposing medications that were originally developed for rheumatoid arthritis to help control inflammation in the gut, in the lung, in the joints. And obviously those are off-label, those weren't necessarily made for those indications, but rheumatologists get involved to help steer the course because we have so much experience with those medications. So I wanted to tell you about what we are doing in rheumatology at the Brigham. So actually, we have reserved clinic slots every calendar day, Monday through Friday, so that outpatient referrals are urgently seen. So we typically get patients within 3 to 5 days for their first visit, and we understand that many oncology patients travel great distances. They're often in clinic seeing their oncologist, and we want to be as flexible as possible to help offer them spots throughout the entire week. We also have a great bioinformatics core at the Brigham and are able to identify every single initiator of these medications and sort of form retrospective cohorts that aren't looking for patient recruitment, so it's a bit less biased because we know that all of these patients got treated and we can look forward for outcomes. We also have a prospective registry research study called Radios, where we log biologic specimens to get cells, plasma, serum, DNA, RNA, as well as synovial fluid and tissue. We also have standardized physical exam findings, and we also have our patients fill out surveys. So the only research I'll show here is related to some of the similarities and differences between the checkpoint-induced inflammatory arthritis, or ICIA, which is in the bottom left, rheumatoid arthritis in the middle, psoriatic arthritis on the right. Basically, these are cells from within synovial tissue, the actual fluid within joints, and all of these are coded so that they're different types of cells. So the purple are all, these are all T cells, but they're all sort of similar T cells. And you can see that there's some similarities and differences, and in particular, within the arthritis, there's a particular cell, CD38 high cytotoxic CD8 T cells that seem very specific for this. So a lot to learn about our diseases, but there are some novel things about what happens here. So MGB-Wide has been a leader in this area as well. At MGH, they have an immunotherapy toxicity service that has really integrated very well across their campus as well, and we're great collaborators with them as well to share resources, and they have a great tissue bank based on colon biopsies, lung biopsies, et cetera, to help understand some of the molecular targets about what's going on here. And maybe I'll let Nicole end on this slide, and we can go to the Q&A here.
You guys hear me?
Yeah, I think just talk.
Can you unmute me?
There you
go. So this is Connor, and it always comes back to the patients, and I think it's really critical, but Connor was 7 when he was cured of his leukemia. But he suffered from graft-versus-host disease affecting his lungs, his skin, and his eyes, ultimately resulting in a bilateral lung transplant. Throughout his course, he required a medication called voriconazole to treat fungal infections of his lungs, which made his skin very, very photosensitive. And he developed many, many skin cancers. So he lived through his leukemia, then his graft-versus-host disease, then his lung transplant. And then he transitioned to us in the adult Dana-Farber Cancer Center when he developed squamous cell carcinoma of multiple sites, had his thumb amputated and survived his first metastatic event, but ultimately developed squamous cell carcinoma that spread to his lymph nodes. And we were faced with trying to decide whether to give him a checkpoint inhibitor, which has a 50% response rate in squamous cell carcinoma. And Connor said, unless you can tell me that I'm not going to reject my lungs or get pneumonitis, I'm just not going to take it. And we are not there yet. So we couldn't tell him we weren't going to flare his GVHD. We couldn't tell him we weren't going to reject his lungs. We gave him a plan for how we would approach it. But he ultimately died because we couldn't manage the side effects of his cancer. And his cancer was caused as a side effect of his original cancer. So his mother has gone around, he was 23 when he died. And this is a quote from a fundraiser even before he had the squamous cell. And she said that his case stresses to all of us how important the continuation of research is to not only find ways to cure cancer, but ways to cure it humanely. And I think that the term humanely is one that people cringe when they hear it, but it's true. He died a very inhumane death and suffered the consequences of our cancer treatment for his entire life, and he was an amazing kid. So something to remember, and someday if we have the funding, I hope to have the Connor Flanagan Center for Oncotoxicity Prevention and Management, because he really is an inspiration to many, many people at Dana-Farber for the last 20 years.
Great. Well, thank you, Nicole and Jeff, for a wonderful, wonderful session. So now we're going to open up to Q&A. Questions? I see a question up front over there.
Hi, thank you for this presentation. Is there a way to identify patients at risk of having side effects from immune checkpoint inhibitors? for example, based on family history or based on the cell populations and the circulating immune cells, something like that?
Not definitively, not well, and not yet. So I would say that there are many, many teams of people working on developing predictive models and biomarkers for the risk of immune-related adverse events. We know that women, for example, are at higher risk than men in some general studies. We know that having a prior history of autoimmune disease, and therefore we extrapolate to family history, puts some people at a higher risk of autoimmune disease. But we don't know to what degree. But there are a lot of studies looking at different biomarkers. So baseline IL-6 level is associated with a higher risk of developing it, but we have not come up with a comprehensive model that includes germline, genomic factors, sex-based factors, and baseline laboratory values to predict side effects. And so there still is this big idiosyncratic piece, which I think is why I always say the mechanisms are very much multifactorial. And they have to include our environmental exposures, our viral exposures, and things like that at various time points as well. That's my understanding.
Yeah, I think this highlight, again, I think you hit on a good point, because we know when these drugs are started, and in theory we could measure a lot of things right there and look forward in time. Unfortunately, it's been a very complex field just because there's so many different types of organ systems that are involved, and the severity is very different. So I think we quote that at least 50% of patients have at least one immune-related adverse event. And I think a lot of the research has been looking at specific manifestations. And then when you look further out as far as any manifestation, a lot of the signals cancel each other out, because they might have some genes that put them at risk for colitis, but maybe they have other genes that put them at lower risk for something else. And then if you look, it kind of is a wash. So I think it's been a little bit of a tension between looking at organ-specific toxicities and the wider net. And clinically, we often really care about the severe toxicities that are going to interrupt care and could be lethal even in patients. And again, those seem quite idiosyncratic. In particular, myocarditis is one of the feared complications for this. Luckily, it seems very uncommon, but if it happens, it can be very tough to treat and refractory. So it's so uncommon that it's been hard to really pinpoint why people get it.
Thank you.
Question over there.
So just kind of thinking out loud here, PD-L1 is not it's not a tumor antigen. It's a ubiquitously expressed don't kill me signal. All sorts of normal cells use it, which is why you get this very broad range of toxicity and organ side effects. So what's the basis of believing that one can ever really get around these side effects by using these anti-inflammatory molecules? It seems like it's fundamental to this modality of treatment.
It's fundamental, and yet half patients don't get immune-related adverse events. So I think we do see different side effect profiles with PD-L1 inhibition. We definitively see different side effect profiles with CTLA-4 inhibition from PD-1, PD-L1. Again, I think historically there's been a lot of lumping when we should have been splitting, right? So people just put all the PD-1 inhibitors together even though they have different backbones, and there may be differential side effect profiles and response profiles within them. So I think until we are really granular and describing everything, we have a very hard time studying it. The way we get around it with what we have now is we look, from me, the first place I look is morphologically. I know the clinical manifestation. I know what we understand about that clinical disease. I'll use the autoimmune bullous pemphigoid, for example. I understand the pathways and the cytokines that are elevated in patients who have that in the idiopathic setting. I want to target those pathways as specifically as possible and leave the rest of the immune system alone to fight the cancer, whatever the mechanism. And so right now we're sort of stuck looking at what we have and what we know and working backwards. But there are clearly people who, despite the ubiquitous expression of PD-1, PD-L1, get great responses and don't have side effects. So I think we need to learn as much as we can from all of these populations retrospectively, because that's what we have.
If I could just do a quick follow-up.
Yeah.
The targeting of cytokines that are driving the inflammatory response, these are the same cytokines that are also driving regression. They're inducing apoptosis in the tumor cells. Do you have concerns that inhibiting the immune response against inflammation is also going to undo some of the benefits of immunotherapy?
This is the tension in clinic every time
Always.
when one of these patients comes here, because theoretically it makes sense that you're kind of toning down how well these drugs are working, and is that going to translate into worse cancer outcomes? So it's always a bit of a balancing act. And I have to say, in my experience, the risk is a bit more theoretical. There hasn't been really hard data about how that these actually affect outcomes negatively.
Well, the alternative is where we were, which was that everyone got globally immunosuppressing high-dose systemic steroids. So 1 to 2 milligrams per kilogram of prednisone equivalent is broadly and globally immunosuppressing. Cyclosporin, like knock out all the T cells. I know you guys use it, but I don't love it. So it's the constant discussion, right? So when we look at psoriasis, it really makes my head explode because we don't use systemic steroids to treat psoriasis. So globally immune suppressing a patient with systemic steroids doesn't make any sense. We know the Th17 pathway may be involved. We know we can hit IL-12, 23, IL-17. We don't know that those are actually involved in that patient's response to the cancer treatment. We don't know that that pathway truly is. So we're targeting the pathway causing or associated with the toxicity in as fine a way as possible with the data that we have, and hoping that in that patient, that pathway is not involved in their response, and guessing that it's better than globally immunosuppressing them. So it's a constant tension, but that's the conversation.
I'll mention this is a very fast-moving field. Obviously, this was a huge innovation to have immunotherapy, and I imagine that, obviously there's a lot of trials trying to find different targets, trying to make it more specific to cancer. If you could reserve the benefit of these drugs and not have the side effects, even that would be a huge game changer. But there's new targets. So there's a lot of innovation in the space, and on our side of things, we have to really keep up on the literature and see what's going on related to all the different immune pathways that could or couldn't be activated. And then from our standpoint, patients who have toxicity, we really need trials to really understand how these help treat patients and what their cancer outcomes are. And so luckily there does seem to be some momentum to actually get appropriately powered trials that could help us understand how to actually treat these manifestations.
Question in the back over there.
So I just have a comment regarding inflammation in general and following the literature. Inflammation is not just proteins IL-6, TNF, is also lipids release. The most known anti-inflammatory is aspirin, which is a COX inhibitor. So I wonder whether, for example, in rheumatoid arthritis, where there is foam cell formation similar to in cardiovascular diseases, and the lipids are involved, whether you think about a little bit outside of the box, instead than targeting only proteins, targeting enzymes that make lipids or receptor for lipids. Actually, in obesity, one of the receptors, GPR41, is one of the most follow-on target, and there are clinical studies that prove the efficacy of inhibiting GP41. Similarly, for side effects in cancer therapies, I wonder whether any of these drugs is really compromising the ability of the cells to interact, because they change the plasma membrane and they change the ability of phagocytosing cell to clear the tumor.
So it sounds like there may be two parts of the question. Maybe I'll have Brittany take one, and then I'm going to have one of you guys take the second part.
And I think if I understood it right, you're asking about getting more specific on the pathways and also dealing with some of the different side effects of some of the common drugs we use in cardiology. And I think that I agree. I think we're learning more and more about how to target these different pathways. I still, as a cardiologist, think statins are very effective medications in reducing cardiovascular risk and also targeting lipids, but it's not the only tool we have in our toolbox now in 2023. And in fact, I speak to many of my patients about other therapies. Oftentimes I'm dealing with insurances that say you have to show me that patient has a side effect, but now we have very specific ways to lower cholesterol with PCSK9 inhibitors. And just as one example of a patient in my clinic who has dermatomyositis, a disease that I'm not going to put that patient on a statin, I felt very strongly, given they have an associated myositis, I fought with the insurance and got that drug approved. I agree with you on anti-obesity management that the GLP-1 field is just exploding in terms of what we're understanding. These were drugs that were marketed for diabetes, but what I finding fascinating as a cardiologist is that the data showing that these are our first drugs with weight reduction, so cardiovascular risk reduction. I think the challenge is that I rushed here from clinic today and I spoke to 2 patients this morning, all really would love to be on this therapy, and I think they're going to reduce their risk because I know their BMI is associated with excess risk, but we're dealing with insurance payers who I can't get these drugs approved and they can't afford it out of the pocket. So I think we're learning more and more. There's still more to come, but we also have a lot of challenges that's beyond just being able to have the therapies for the patient. It's access.
I think I didn't catch every part of the question. It sounds like you're talking about repurposing medication, thinking outside the box. I think obviously in patients who have cancer, it's a little bit of a different, there's different goals, there's a different patient population, and I think there's definitely a lot of thoughts related to GLP-1 and SGLT2. For a lot of these patients, it's really trying to think about, they have these toxicities, how do we treat it quickly, get their quality of life better, try to, make it so that they're not hospitalized. And certainly we want to get to the point where there's a more long-term vision, because a lot of the trials are really focused on short-term outcomes related to cancer progression-free survival. So I'm hoping that this will usher in an era where we start thinking about this as a manageable chronic disease, just like diabetes.
I just like to pull on the approach you mentioned about the insurance companies.
Yeah.
How do you get them out of the way?
You can't.
Is there a vision for the next 5 to 10 years? Because I have numerous friends and relatives that they can't get to the drug that they need until after you've shown they failed or they had severe side effects. Is there any way to change this?
I wish I knew the answer to that question, because it was surely.
This audience could
but I think this is the idea of a forums like this of innovation. I fight for my patients. I write letters. I cite the New England Journal of Medicine paper showing benefits. I try everything I can, try coupons. It's a challenge.
Yeah.
It's insulting to you guys that you have insurance guys dictating.
It is.
Right. I use a lot of cardiovascular imaging, and I can't tell you, every single week I am literally emailed by the hospital that I have to do a prior authorization to get an imaging test approved that's clearly indicated. But the challenge is that it doesn't hit their algorithm on why a patient needs a PET scan. So then I spend an hour on the phone, and usually it always ends up, I can tell you, and the right thing is that the non-cardiologist says they don't have the information, so then they have to set up another appointment. And so this is a huge challenge. It's a huge burden on the medical system.
It's a huge challenge across all our specialties.
Yeah.
It's really the cost of medical care is so high here. I'm not saying the insurance is the answer to it, but they're trying to get discounts and pay the least as possible, and it's a broken system.
And from the cancer perspective, Nicole, I'm sure, can chime in too, but the trials were not done in this setting. We're using it for rheumatoid arthritis, and it's not even going to end up on the algorithm. And honestly, we really, time is precious here. We want to limit the amount of steroids they're on. So, and we're sometimes using, alternative dosing that's more frequent or in higher doses. So it's obviously a major challenge in the cancer patients.
There's a person in my department, Avery LaChance, who is our advocacy queen, and she, I know, has pushed through a step therapy bill to try to eliminate the requirement for step therapy. I don't know how expansive that bill is, but I'd be happy to connect you with Avery, because she knows all of the avenues to try to make progress to improve the things that drive us nuts. But you're right, it's insulting and it's very frustrating, especially for diseases. So some of the autoimmune diseases that the checkpoint inhibitors cause don't have any FDA-approved drugs to treat them, even in the idiopathic setting. And so the insurance won't cover a non-FDA-approved drug, and I've got nothing. So Mark Cuban's pharmacy is like, woohoo! I search Mark Cuban's pharmacy, GoodRx. We spend all of our time with our patients looking for coupons to try to keep them alive, and it's very maddening. But we don't have the answers, and you don't want us spending our time finding the answers because we're busy.
Yes, exactly.
All right. Well, final quick question. We have 1 minute left.
Sorry. As we have more and more therapies that are using or manipulating the immune system, I've heard a number of patients somewhat naively say, "Oh, it's cell therapy. It won't be as bad as chemo." And you go, "I don't think you know what cell therapy looks like." How do you, especially when you look at a number of cancers that have second, third, fourth line treatments, that you have toxicity, you have all sorts of things that are going to make the next levels all that more challenging. How do you think you can manage those expectations for patients so that as they're looking and saying, oh, it's not like chemo, it's going to be different?
Yeah, I think every conversation with a patient needs to be patient-centered and balance risk and benefit with that long trajectory in mind. So again, it's not just your ALL treatment, it's your stem cell transplant, it's your complications of stem cell transplant and what we will do in that setting. So in hindsight, Connor should maybe have tried an alternative antifungal than voriconazole because he's, the little Irish boy who was going to have his whole life to get skin cancer. I think it's just a really frank discussion of risk and benefits. So if you look at the melanoma setting, when I've cut out your melanoma, you no longer have any melanoma, and we're going to decide whether to give you adjuvant BRAF/MEK inhibitor targeted therapy or immunotherapy. If you're 35 and I knock out your pituitary or your thyroid, you're going to be on thyroid replacement therapy for the rest of your life, or maybe you'll have type 1 diabetes and all of the cardiovascular fiascos that come with that. If I give you BRAF/MEK inhibitor, you're going to feel uncomfortable and gross and yucky for a year, maybe, and have a bunch of side effects that hopefully are reversible. So the conversation for a 35-year-old versus a 75-year-old are totally different, and I think it's most important to just be open to think with the patient's values in mind and what they need to understand for their own life, and to just be honest and have a nice dialogue back and forth. It's the best we can do.
Well, this is a great way to end the session, our move toward precision medicine and personalized medicine. So thank you all for coming.